Okay, should be good to go now. Okay, so I'm just going to start with the first two lectures tonight just because there was a ton of physiology and, I'm trying to keep it light um, just so people have time to go through the material. So Sunday's session will be a lot heavier. But hopefully this will give you guys a start. Okay, so a lot of review from endocrine physiology in this lecture. So you have your anterior pituitary, which is the adenohypophysis, and it's going to produce and release 6 different hormones. So kind of a throwback to an MCAT mnemonic, flat pig. So FSH, LH, ACTH, TSH, prolactin, and growth hormone. And then from your posterior pituitary, rather than producing, it's storing and releasing both ADH and oxytocin. So, what is the function of prolactin and oxytocin in regards to milk in the mother? So, what does prolactin do? Okay, and what does oxytocin do? Right. So, just an important distinction there. Okay, now let's go through the different types of growth hormone deficiencies. So, if you have a normal axis, your hypothalamus is going to release GHRH, so growth hormone releasing hormone, and that's going to stimulate the anterior pituitary to release growth hormone, which will reach the liver, and that's going to stimulate the production and the release of IGF 1. So, this is under normal circumstances. And then, if you have what's known as growth hormone insensitivity, your liver is unresponsive. So, you'll have growth hormone released from the anterior pituitary and it's reaching the liver, but the liver is not responding. So, you'll see a decrease in IGF 1 secretion. And then, in a secondary growth hormone deficiency, your anterior pituitary is secreting low growth hormone. And so, because there's not a lot of growth hormone reaching the liver, you're not getting the production of IGF 1. So, you have a decrease in both growth hormone and IGF 1. If you have a tertiary deficiency of growth hormone, this is a hypothalamic dysfunction. So in that case, you're getting decreased GHRH from the hypothalamus. If you don't have any GHRH stimulating the anterior pituitary, you're not going to see any growth hormone release, and then you're not going to see any production of IGF 1 by the liver. And then finally, in this last step, if you have an anterior pituitary adenoma, that's going to lead to growth hormone excess. So basically, you have a bunch of growth hormone reaching the liver, stimulating the production and release of IGF 1. And then that IGF 1 is going to have minimal feedback inhibition on the growth hormone and that's due to the presence of a tumor. Okay, so basically what I said there is all in words. So if you're a words person, there's the words. Oh, and then also another important thing to keep in mind is the fact that somatostatin inhibits growth hormone, and then ghrelin stimulates growth hormone. So where is ghrelin released from? Thinking back to GI. Anybody? So ghrelin is right, yeah. It's released from the stomach. Good. Okay, words. Okay, so starting with our growth hormone analogs, so somatotropin is recombinant human growth hormone, and it's going to be used in growth hormone deficiency in both children and adults. Children with genetic diseases that is associated with short stature, and also AIDS-associated wasting and growth hormone deficiency. So what are some genetic diseases in children that are associated with short stature that you would have talked about in MFM1? Can you think of any? So you guys talked about Turner syndrome, right? So Turner syndrome, Prader-Willi syndrome, Noonan syndrome. Those are just some examples that you would use recombinant human growth hormone to treat the short stature that you'd see in those patients. And then some of the adverse effects are pseudotumor cerebri. And I wanted to point this one out. This is actually the old name. Do you guys know what the new name for this is? Pseudotumor cerebri? Did you talk about it? I feel like maybe Dr. Dubisky might have talked about it. So does idiopathic intracranial hypertension sound familiar? Maybe not. Okay, if not, it'll definitely come up in neuro in the fall. So pseudotumor cerebri is kind of the old name. They refer to it now as idiopathic intracranial hypertension. And that's probably a good thing because it's kind of telling you what the problem is. So with pseudotumor cerebri, you're going to have increased intracranial pressure, and that's going to lead to problems like headache and vision disturbance. Okay, and then also an important thing to point out is that somatropin is going to lead to hyperglycemia, whereas mecithermin, you'll see hypoglycemia. And then mecithermin is used in Leroy dwarfism, and this is a type of dwarfism where patients are deficient in IGF-1. So the somatropin would be used for like a pituitary dwarfism, whereas this is a IGF-1 deficiency. Okay, so growth hormone antagonists. The first two are octreotide and lanreotide, and these are both somatostatin analogs. So remember, somatostatin inhibits growth hormone. These are both used to treat somatotroph adenomas. So your somatotrophs release growth hormone, so growth tumors that cause an excess in growth hormone release. Bromocriptine, this is a really important one. And bromocriptine is a D2 receptor agonist, and it's going to inhibit prolactin release. So what is the physiologic relationship between dopamine and prolactin?
Dopamine degrades it.
Right, so dopamine inhibits prolactin. So if you increase dopamine, you're going to see inhibition of prolactin, whereas the other way around, if you have a decrease in dopamine, you're going to see an increase in prolactin. And this is used to treat somatotroph adenomas at high doses. It's used to treat acromegaly, and then also hyperprolactinemia. So that makes sense because if you're giving a D2, a dopamine receptor agonist, you're going to inhibit prolactin. So if you have someone with hyperprolactinemia, D2 agonism is going to decrease the prolactin. And that's a really important point. And then the last one is pegvisomant, and this is going to prevent receptor dimerization. And it's going to be your best choice for the treatment of acromegaly because it doesn't require the high dose like bromocriptine. So what's the difference between acromegaly and gigantism?
One you get before puberty, and the other one you get after it. I just don't remember which is which.
Yeah. So your acromegaly is later. Yeah. So you're right. So acromegaly occurs in adulthood. So kind of like the delineation is when the epiphyseal growth plates close. So gigantism, you'll see like a linear increase in growth. So, obviously the person's going to be super tall, and that's because your epiphyseal growth plates, they haven't closed yet. Whereas in an adult, if you have too much IGF, the growth plates have already closed. So instead of seeing a linear increase in growth, you're going to see like an increase in the size of the bones. So like a lot of questions will talk about like a protruding jaw or a protruding forehead or something to do with the facial bones looking really prominent. Does that make sense? And something I talked to Dr. Quadri about, so somatotroph adenomas can actually cause acromegaly, and that's true in it's like 95% of the cases. Like almost always, acromegaly is caused by a somatotroph adenoma. But the reason that you would use pegvisomant over octreotide is for that off chance that you have like an ectopic cause of acromegaly. So just in case the acromegaly is being caused by something other than pituitary adenoma, this would be your best bet as far as drug choice. In case anybody had the same question. Okay, so super important to understand the relationship between dopamine and prolactin. So, any disease that interrupts the hypothalamic pituitary portal system is going to result in decreased secretion of most anterior pituitary hormones, but you're going to see an increase in prolactin release. Can somebody explain like why that is? So if you see a disruption in the HPA axis, Why do you get a decrease of the other anterior pituitary hormones but an increase in prolactin? Right, exactly, because there's less dopamine being sent down and it's not inhibiting the release of prolactin. Okay, how about why does hyperprolactinemia cause infertility? So why do you see infertility with hyperprolactinemia? If you look over this at this picture, it kind of tells you. So what is prolactin inhibiting?
GnRH.
Right, GnRH. So if you're inhibiting GnRH, you're not going to see the release of LH or FSH. Of course, your LH surge is important in ovulation. So, kind of long story short, leading you down the road of infertility. Okay, so again with bromocriptine and then also cabergoline, these are both your D2 receptor agonists, so used to treat hyperprolactinemia, infertility, and then also acromegaly in high doses. I would definitely kind of expect to see some sort of question about dopamine and prolactin and your D2 agonists, whether it's asking like what is the appropriate drug or testing you on the use or like the physiologic relationship. That's just something that's really important and that comes up a lot second year. So if I were to guess like one of his WeBots, definitely something to do with dopamine and prolactin. Okay. So next is vasopressin, which is ADH. So ADH is going to be secreted by the posterior pituitary. What's your other hormone that's secreted by the posterior pituitary? Right, oxytocin. Good. So you get the secretion of ADH in response to an increase in osmolarity, a decrease in blood volume, or a decrease in blood pressure. So with any of these, ADH is going to be beneficial because if you think ADH being your anti-P hormone, you're going to retain water. So if you're retaining fluid, instead of an increase in osmolarity, you would see a decrease in osmolarity, an increase in blood volume, and an increase in blood pressure. So it would reverse those effects. And then two drugs to know here are desmopressin, which is your vasopressin agonist, and it's going to bind to the V2 receptors in the collecting duct, which leads to the insertion of aquaporin channels, and that allows water to diffuse back into the bloodstream. But something you hadn't read is that you should understand that it's just water and not sodium. And then conivaptan and tolvaptan. Those are your two drugs that are used to treat hyponatremia. And if he was going to test you on one of these, my guess would be like conivaptan or tolvaptan because you've talked about it less, and then he could easily talk about hyponatremia and ask what you were going to treat it with. Okay, and the important adverse effect is the fact that it's hepatotoxic and leads to life-threatening liver failure. So just a review of thyroid hormone. So you have TRH being released from the hypothalamus, and your TRH is going to stimulate the anterior pituitary to release TSH, which stimulates the thyroid gland to release T3 and T4, and that's going to feedback inhibit your anterior pituitary. And then also something that I always forget, or that like I personally feel like is hard to remember, that TRH is stimulating the release of prolactin as well as TSH. And let's see, we talked about TSH stimulating the release of thyroid hormone, and then it's also going to increase the size and the number of the follicular cells. Okay. So I just took this straight out of Dr. Quadri's slides. Go back. All right, so we'll just walk through this physiology real quick here. Okay, so over on this side, you have iodide that is transported by, it's actually a sodium iodide transporter. So it's transported into the thyroid follicular cell, and it's going to undergo, so I kind of added a few things here, the stuff in bold. I added just so, I don't know, you hear stuff like organification, deiodination, and it's kind of important to remember those words. You'll see that in question stem. So anyways, so you have iodide that's transported into the follicular cell, and it undergoes an oxidation reaction by the use of this enzyme thyroid peroxidase, and then it's going to form iodine. And then also at the same time, thyroglobulin is going to move into the colloid. And then you have this reaction here that's known as organification of iodine. And that's a reaction that involves iodination of tyrosine residues on thyroglobulin. And then next there's a coupling reaction that occurs by thyroid peroxidase. And this is going to combine either DIT and MIT to produce T3, or DIT and DIT to produce T4. And then your thyroid follicular cells, they're going to endocytose the thyroglobulin, and then you'll have proteases that cleave the T3 and T4 off of the thyroglobulin. And your T3 and T4 is released into circulation, and then your leftover MIT and DIT undergo a deiodination reaction, and they're going to have iodide that's recycled. Okay. So the only reason I would say that this physiology is important for this exam, at least, is when we talk about the drugs, you need to know where or what step each drug is acting at. Okay. So he went into quite a bit of detail here, but kind of as long as you remember your basics, you'll be fine. So your beta cells are going to be located centrally, and he described those as your Beyonce, you know, who like wants to be the center of attention. And then your alpha cells are releasing glucagon, and they're surrounding the beta cells because they're like the celebrity photographer, you know, they want to be around Beyonce. And then your delta cells are going to release somatostatin, and those are kind of found everywhere because, you know, everybody can have a dog, including your photographers and Beyonce. So just remember what each of these cell types are secreting. Okay. And I thought first aid did like a good job of simplifying this physiology of insulin secretion. So, if you come down here, it talks about the fact that glucose enters the beta cells via the GLUT2 transporter. And then you're going to have an increase in ATP, and that's generated from glucose metabolism. And then the increase in ATP is going to close your potassium channels. And when you close the potassium channels, you don't have these positively charged ions leaking out. So you have more positive charge building up in the cell. So as a result, instead of like sitting at -70, you're going to rise to like about -50. So the charge inside of the cell is becoming less negative. And because of that, your voltage gated calcium channels are going to open, and you'll see an influx in intracellular calcium. And then because of that, that is going to stimulate the exocytosis of insulin. So you'll see insulin being released from your pancreatic beta cells. And I mean, this is really the extent that you need to know this. Okay. So a few questions here. A 12-year-old female presents to the clinic with short stature, broad chest, with widely spaced nipples, webbed neck, and lymphedema of the head, hands, and feet. Which medication will treat her short stature? So what am I describing in this question stem? Like what disorder? Short female, webbed neck. Sorry, go ahead.
Turner's syndrome?
Yeah, that's right. So Turner syndrome. So that would be a genetic cause of short stature. So what drug would you use to treat her if you have a genetic cause of short stature? Very good. So C is the correct answer here. Oh boy. Okay. I don't know if you guys saw that, but it said I got a gift from Zoom and they removed the 40-minute time limit on our meeting.
Brent, you have a question real quick?
Yeah.
What are the other diseases? It was Prader-Willi, Turner, Prader-Willi, and the other one?
Oh, yeah, that was just some examples. So, like Turner's Noonan syndrome, which have you guys even talked about that? If you haven't, like, obviously that's not something they're going to bring up on the test.
Okay, I couldn't remember if we did or not, so I was just checking just to make sure I had it written down. Thank you.
Yeah, you're welcome. Okay, so second question. A 45-year-old female presents to the clinic with fatigue and recent onset of joint pain in her knees, shoulders, and wrists. You notice her cheekbones are pronounced and her jaw appears enlarged. Which medication are you going to treat her with? Right, so you guys are right. So the correct answer here is D. And what am I describing in the question stem? Right, acromegaly. So I tried really hard to kind of write my questions how Dr. Quadri does. So he's probably going to give you some findings like this, and then you're going to have to make a diagnosis and then choose the correct drug. All right. Last one, a 30-year-old female presents with galactorrhea due to pituitary adenoma. Which medication will treat the patient? Right, so the correct answer here is B, and why did you choose B?
Because it's a D2 agonist, so it'll decrease the amount of prolactin.
Yeah, exactly. And if you notice, I made a little change here. So more specifically, her problem would be a prolactinoma, but I was trying not to make the question like too easy. Okay. On to this next lecture. Okay, so kind of back to thyroid hormones here. So basically, the point here is just that most of your T3 and T4 are bound by thyroxine binding globulin, so TBG, and only a small amount of the hormone is actually free, and it's the free hormone that is the active hormone. Okay. All right, so this slide is really important, and this is kind of what I was talking about. So, like, you have to know the physiology to be able to make the diagnosis, and that's kind of just, the first step. Like, you have to have the correct diagnosis before you can choose the medication. So, I'll start over here. If you have primary hypothyroidism, so in primary hypothyroidism, you're going to have high TSH and then a low T4 and T3. So, and this is indicating that you have primary thyroid failure. And this is because, you have plenty of TSH heading to the thyroid gland, but the thyroid gland is not responding by increasing the amount of T3 and T4. So, primary hypothyroidism, and you can think of that as like low thyroid hormone. And then down here in primary hyperthyroidism, you have a high T3 and T4, and then a low TSH. So basically, you just have like a hyperactive thyroid gland. So you have plenty of thyroid hormone that's being secreted, and is inhibiting the release of TSH. So you see high T3 and T4, and then low TSH. In central hypothyroidism, you have what's known as a primary pituitary failure, and you're going to see low TSH and then low T3, T4. So in central hypothyroidism, your pituitary is not working, it's not secreting enough TSH. So you're not seeing any increase in T3 and T4. So both of those are going to be low. And then in secondary hyperthyroidism, you have a TSH producing tumor. So you'll have high TSH and then high T3, T4. And then because it's a tumor, even though you have feedback inhibition of the T3 and T4 on the pituitary, it has minimal effect. And that's because you have a TSH producing tumor. Okay, so make sure that you know this chart, because these questions will be like, the patient has X, Y, and Z symptoms. Like T3, T4 is low and TSH is high. So then you need to be able to make the diagnosis based on those findings. All right, and then some of the symptoms that he could describe should be, the obvious ones associated with either hypo or hyperthyroidism. So with hypothyroidism, you'll see cold intolerance, fatigue, constipation, hair thinning loss, and weight gain. And then with hyperthyroidism, heat intolerance and sweating, insomnia, palpitations, and weight loss. Okay, so your thyroid agents are going to be levothyroxine and then liothyronine. And levothyroxine is like kind of your first line or your preferred treatment for hypothyroidism. And then liothyronine is used to treat myxedema coma. So this is severe hypothyroidism. So if somebody is, just walking into the clinic, complaining of some weight gain and their hair is thinning, this is just your typical hypothyroid case. So in most cases, you're going to choose levothyroxine for hypothyroidism. All right. So really, the important thing to know here is what these are being used for. So hypothyroidism versus a more severe form of hypothyroidism known as myxedema coma. So this next slide are your anti-thyroid agents. So these are your thioamines, and those include methimazole and propylthiouracil. Both methimazole and propylthiouracil are going to inhibit thyroid peroxidase. So go back to that slide where the physiology is, and make sure you know where that is, in the synthesis of thyroid hormone. The only other thing here would be the fact that this one is safe in pregnancy, whereas propylthiouracil is not. And then also, the most important adverse effect here is going to be agranulocytosis, and that's because it's potentially fatal. So, obviously, any of the side effects that could potentially kill your patient, you definitely want to know about. Okay. The next group of antithyroid agents are going to be your iodides. So I'm not 100% sure, so I did some kind of reading on my own to make sure, but I'm pretty sure that Lugos solution is just potassium iodide in water. So I don't know if that is easier for people to take or what, but really they're doing the same thing. One of them, this one is just potassium iodide dissolved in water with iodine. But the mechanism of action here is that they are going to inhibit iodine organification, block the release of T4 and T3, and then reduce the size and vascularity of a hyperplastic gland. And this is very important to know to understand the use of potassium iodide. So potassium iodide is given in preparation for surgery on the thyroid gland. And that's to help reduce the size and how vascularized it is prior to surgery. Let's see. Then also you have something known as the Wolff-Chaikoff effect, and this is an autoregulatory reduction in thyroid hormone levels caused by the ingestion of a large amount of iodine. And then the Job-Basedow phenomenon. This occurs if autoregulation is absent. So if you don't see a decrease in thyroid hormone levels in response to ingestion of a large amount of iodine, you're going to see thyrotoxicosis because you don't get this autoregulatory inhibition. So you see an increase in thyroid hormone synthesis, leading to thyrotoxicosis. Okay, then an important adverse effect is the fact that the iodides can cross the placenta and cause a fetal goiter. So this would be something that is contraindicated in pregnancy. All right. So I did a little editing to one of Dr. Quadri's slides just to help show you exactly where these drugs are acting. So your thiamides inhibiting thyroid peroxidase, and then your iodides saturating the sodium iodide transporter, and then transiently inhibiting the organification of iodine, and then also blocking the release of T3 and T4. So important just to make sure you know where they're acting. Okay, our final anti-thyroid agent is going to be radioactive iodine. And this is used in the treatment of thyrotoxicosis when the patient, for whatever reason, isn't a candidate for surgery. And this is going to result in permanent reduction in thyroid activity. So basically, you're kind of inducing a permanent hypothyroid state. And also another drug that is contraindicated in pregnancy because it crosses the placenta and is excreted in the breast milk. And this, just some other drugs that he talked about. So beta blockers, your glucocorticoids, and amiodarone. Just recognize that they're going to inhibit peripheral conversion of T4 to T3. And the only one he really kind of emphasized here was aspirin and NSAIDs. So these are going to decrease protein binding, so result in an increase in free thyroid hormone. So if you have a hyperthyroid patient who presents with a fever, you're not going to want to give them an NSAID to reduce the fever, because if you're increasing the amount of free thyroid hormone, this is going to kind of make their hyperthyroid state worse. Sorry, this looks a little blurry. But just to review the histology of the adrenal cortex, which is really high yield. So your zona glomerulosa is going to produce aldosterone, which is regulated by angiotensin 2. Your zona fasciculata is going to produce cortisol, and then zona reticularis is going to produce your DHEAs, which are eventually converted to testosterone. And then, of course, your adrenal medulla producing epinephrine and norepinephrine. Okay, so just kind of important to understand the regulation of cortisol. So you have CRH that's released by the hypothalamus, and this is going to stimulate ACTH release from the anterior pituitary. And that's going to lead to cortisol production from the zona fasciculata. And the cortisol production is going to feedback inhibit both the anterior pituitary and the hypothalamus. All right. And then just some of your important effects of cortisol. So First Aid uses this mnemonic called a big fib to help you remember those, maybe. I'm not sure if that's helpful at all. Okay. Okay, so next we're going to talk about the types of adrenal insufficiency. Okay, so in primary adrenal insufficiency, so primary is referring to the loss of adrenal function. So you have your anterior pituitary, which is secreting ACTH, and due to the loss of adrenal function, your adrenal gland is going to be unresponsive to the ACTH. So as a result, you're going to see a decrease in both cortisol and aldosterone secretion, and this is going to decrease the feedback inhibition. And then also, it's important to know that with primary adrenal insufficiency, you're going to see hyperpigmentation of the skin and mucosa. So you can remember that primary pigments the skin, and then secondary spares the skin. So in secondary adrenal insufficiency, you have an unresponsive anterior pituitary gland. So your anterior pituitary gland is going to secrete less ACTH, and because you're secreting less ACTH, your adrenal gland cannot produce cortisol. However, a very important point to realize is that secretion of aldosterone is spared, and that's due to its regulation by angiotensin II. And then also, because you're not getting that production of ACTH, you're not seeing the hyperpigmentation of the skin, and that's because MSH is a byproduct of ACTH production. And then a little bit lower yield here would be tertiary adrenal insufficiency, and this is due to withdrawal of high doses of exogenous glucocorticoids. So basically, if you're taking an exogenous drug, you're getting a lot of feedback inhibition to the point where your HPA axis is not really responding. And that's because you've been on the drug for so long and it's kind of suppressed the function. So it takes a while for the HPA axis to kind of wake up. So that's one of the reasons that you would taper slowly when taking a patient off of these drugs. All right. Next is Addison's disease. So Addison's disease is also known as primary adrenal insufficiency. So if you remember that primary pigments the skin, that should help you remember that one of your big findings or kind of big giveaways in questions is the fact that the patient is going to have hyperpigmentation of the skin and mucosa, and that's due to an increase in MSH, which is a byproduct of ACTH production. And then also a big one is the fact that you'll see hyperkalemia, and that's due to a lack of aldosterone. So why can you not just give a patient exogenous aldosterone to treat the hyperkalemia seen in Addison's disease? He mentioned it in lecture, but it was just kind of in passing. Right, exactly. So aldosterone is inactivated by the liver, so you can't just give the patient exogenous aldosterone, but instead you give them fludrocortisone, and that increases the reabsorption of sodium, and it fixes your loss of potassium. So two of your big serum findings in Addison's disease is going to be decreased serum sodium and then increased serum potassium. So to fix that, you're going to give fludrocortisone. And then also, so to treat Addison's, in addition to the fludrocortisone, the big one is hydrocortisone. So oral hydrocortisone is the drug of choice. And then also something you hadn't read is the fact that prednisone is safe in pregnancy because the placenta does not convert prednisone to prednisolone. Because I guess the liver isn't developed enough at that time to do that. And then your adverse effects of hydrocortisone are going to be hypertension, hypokalemia, and hyperglycemia. So basically seeing the reverse of what you would see in Addison's. All right. Cushing's syndrome. There we go. Okay. Okay, so Cushing's syndrome, kind of 3 different ways that this can present. So in the first example here, if you have an adrenal tumor, this is referred to as Cushing's syndrome. Or if you have an ectopic ACTH secreting tumor, also Cushing's syndrome. But if you're talking about a pituitary adenoma, then it's referred to as Cushing's disease. So with an adrenal tumor, you're going to see an increased secretion of cortisol by the adrenal cortex, and then the cortisol is going to feedback inhibit the ACTH released by the pituitary gland. However, your circulating levels of cortisol are going to remain elevated, and that's due to the fact that you have an adrenal tumor. Okay, the second example here is referring to an ectopic ACTH secreting tumor. So one of the common examples is small cell carcinoma of the lung. So it can produce ACTH from an ectopic location, and then the ACTH is going to increase the synthesis and the secretion of cortisol released by the adrenal cortex. And then the increase release of cortisol is going to feedback inhibit the release of ACTH by the pituitary gland. However, your circulating levels of ACTH are going to remain elevated due to the fact that you have, a tumor in an ectopic location that's also secreting ACTH, and it's not just coming from the pituitary gland. And then the last one here, so your pituitary adenoma, that's referred to as Cushing's disease, and you're going to have a pituitary tumor that leads to excessive secretion of ACTH and then increased synthesis and secretion of cortisol by the adrenal cortex. And then again, you're talking about a tumor situation, so your negative feedback of cortisol on the pituitary is going to have minimal effect. And that's because that tumor just keeps going. All right. So, Cushing's syndrome. If you're asked to identify Cushing's in a question stem, he's going to give you like the very obvious findings, and that's going to be the description of the moon facies, a buffalo hump, and abdominal striae. Like those 3, in my opinion, are kind of the biggest giveaways, which would be like the ones that he would use for this exam. And then in Cushing's syndrome, you're seeing, constantly elevated cortisol levels. So that's going to lead to the breakdown of muscle, bone, and skin. And then because you have elevated cortisol, you see elevated blood glucose levels, which leads to increased insulin levels. And that specifically targets the adipocytes. So it encourages the adipocytes to take up glucose, specifically in the abdomen. So you'll see abdominal obesity in Cushing's syndrome. And then also, just be aware of the fact that in Cushing's you can see hypertension because cortisol is going to promote fluid retention, which leads to an increase in blood pressure because it mimics your mineralocorticoids. So, just be kind of familiar with the findings here. That way you could recognize them in a question. Like, he's not going to hammer you on the physiology or anything by any means. The main thing is that you can, choose the correct drug. Okay, so when you're managing Cushing's syndrome, your first options are going to be surgery and radiation. However, in cases where either surgery and radiation do not work or the patient is not a candidate for surgery, you're going to prescribe medication to control cortisol production. So I would definitely be familiar with where these different medications are working. So I'm just going to kind of skip ahead here to the picture. So your ketoconazole at low doses, it's going to inhibit 1720 lyase and then decrease androgen secretion. However, at high doses, you're going to see inhibition of the side chain cleavage enzyme. So that's going to decrease the release of all hormones. Whereas metyrapone, that's acting on 11 beta hydroxylase. And this is actually a diagnostic drug. So if you're trying to decide where the problem is, is it the hypothalamus, is it the pituitary, is it the adrenal gland, you would administer metyrapone, and based on that response, that would kind of lead you in the right direction. So right here, if you give metyrapone and you inhibit 11 beta hydroxylase, you're going to see a decrease in cortisol. So if you give metyrapone and you see the decrease in cortisol, but you don't see an increase in ACTH as a result, that tells you that your problem is likely either in the pituitary or the hypothalamus. And then the other two are mitotane, which I wasn't able to put on the picture because it's actually acting at the adrenocortical mitochondria. So again, you're seeing a decrease in the release of all hormones. And this is indicated for someone with very severe Cushing's or who has an adrenocortical carcinoma. And then the last one here is the mifepristone. So that drug, you're probably familiar with it. It's used as an abortive drug, but it's actually also a glucocorticoid receptor antagonist, and it is used to treat hyperglycemia and Cushing's syndrome. So you have this drug here, which is your diagnostic drug, this one, which is treating the hypoglycemia, the first one, which you're going to use in very severe cases or in the cases of cancer, and then ketoconazole is going to be kind of like your go-to for your your run-of-the-mill Cushing's syndrome presentation. So kind of like your average Cushing's patient, you're going to go with ketoconazole. It's kind of the first line choice here. All right. So your aldosterone receptor antagonist. I don't think that he'll test you on this again on this exam because this lecture was huge and you've already talked about spironolactone. But just keep in mind, it's aldosterone receptor antagonist. It's used in hypertension, primary hyperaldosteronism, to treat hypokalemia. And then also, I think maybe this might be kind of new. So spironolactone, It's also an androgen receptor antagonist, so it's used in PCOS, female acne, and female hirsutism. So just kind of another use of spironolactone. And then you'll see your adverse effects of hyperkalemia and then gynecomastia, which is a big one with spironolactone. All right. So 45-year-old female presents to the clinic with complaints of fatigue, constipation, hair loss, and a recent 15-pound weight gain. You run a thyroid panel and T3, T4 are low, and TSH is high. Which drug are you going to treat the patient with? So first of all, what is the question stem? What is it telling you that the patient? Yeah, so the correct answer here is B. And why did you choose B? Like, what is the question stem pointing you towards? Right, hypothyroidism. Okay. So another 45-year-old patient presents with sudden fever, chills, sore throat, mouth ulcers, and bleeding gums. Her CBC is indicative of severe neutropenia. She's being treated for a thyroid disorder. Which medication is she likely taking? So think back to that medication we talked about that um, had a really severe blood cell related adverse effect. Caused a decrease in white blood cells. Right, so you're correct. The correct answer is A. So why did you choose A? Right, so with methimazole, agranulocytosis is one of your fatal adverse effects. Um, so what I tried to describe here is like some of the symptoms of agranulocytosis. So kind of the big tip off would have been that her CBC showed you that she had severe neutropenia. So when you have agranulocytosis in this case, it tends to affect your neutrophils the most. So if you have a severe decrease in neutrophils, you're at higher risk for infection and mouth sores and stuff like that. So hence the mouth ulcers and the bleeding gums. Okay. Last one, 55-year-old male presents with pigmentation of the gums, nausea, vomiting, and weight loss. He has hyponatremia, hyperkalemia, and a blood glucose of 60. Which drug will treat the patient? Yeah, and why did you choose D? Right, it's describing Addison's disease. Yep. All right, we are done. Thank you guys for hanging with me. Hopefully they give us screen sharing back on Zoom next time. You're welcome. Yeah, as always, feel free to message me anytime if you have any questions.